All right, our next case, number 3. What I'm trying to do with setting up these case studies is to get you everything that you need to stage the COPD as an A, B, C, or D. First, we need to do the spirometry to make sure they have COPD, right? Or in this particular case, she comes in for hypertension, right? And then we need to say, okay, what's her MMRC? What's her exacerbation history? What's her CAT score? So then we can say what therapy we should put the patient on if we decide that she does have COPD in this particular case. And that's what the case is setting up. So I want you to start thinking that way when you're doing your case findings with your patients. All right, this is her PFTs. You know, interesting enough, in the pulmonary function lab, a big study suggested that the vast majority of people, when they first identified with COPD, they've lost more than half of their lung function, right? We're not being very good about finding this disease early because we have lots of extra lung, right? Expiratory reserve volume and extra inspiratory capacity, so we can do exercise. And if you're fairly sedentary, you can lose half of your lung function without really even noticing a difference. Now, in this particular case, she's lost quite a bit. Predicted for this particular female is 74. She should be blowing 74% of her air out in the first second, and she's only doing 37. Now, really what I want you to highlight on this one is that she also has a very low vital capacity, only 64%. Now, in primary care, testing that's not done in a pulmonary function lab, I want you to always look, if you're evaluating pulmonary function testing, I want you to always look at the volume time curve down here. That's why I have the arrow pointing, the blue arrow pointing. Many times in primary care, the reason why the vital capacity is low is because the patient didn't blow long enough. In other words, they take a big breath and they blow hard and they stop. Now, in this particular case, Miss J.A., she blew for over 10 seconds. So that's not the problem. She's got 3 good loops here that look good. They trace over the top, and she blew for 10 seconds. And so this low vital capacity, right, is starting to make me wonder about, well, we'll find out. Let's see what the next slide says. Okay. What we notice is after bronchodilation, the vital capacity normalizes. In other words, we see a huge change in the post-bronchodilator. Matter of fact, almost a liter more volume comes out. Now, in this particular case, we don't see much reversibility, especially in the FEV1. Matter of fact, there was almost no change at all. It went from 1.11 liter to 1.19 liters. There was only 80 cc difference after bronchodilation. What we notice is we see a nice change, almost a liter change in the vital capacity. This patient had a lot of air trapping. Now, this is more of an emphysemic case. And the reason why is we see a very low diffusion. The diffusion is only about 49% of what's predicted. That's a loss of parenchyma tissue is what we're seeing here. The more parenchyma tissue that's lost, the lower diffusion, because we've lost surface area for diffusion. You know, somebody years ago found out that the average size of an alveolar, right, one alveoli, I guess, I don't know how to say it, but is about this big, and the average adult male has about 300 million alveoli, that the average size for gas exchange is about the size of a tennis court. Well, if you keep decreasing the parenchyma tissue by breaking it down, you get less and less surface area for gas exchange. And also, this particular patient shows us that the patient had very significant air trapping. And our goal in therapy for this particular patient is try to decrease the hyperinflation and air trapping so that the work of breathing will go down. We can't really change the emphysemic part, the diffusion part, but we certainly can maybe do some therapy here by getting her on good bronchodilation so that she is more functional. She can walk around and do more. Patients that can't walk around and do stuff without being really short of breath end up with cardiovascular decline. And so the idea is to kind of shore them up so they can breathe well enough to move around and stay physically in shape. So she had this MMRC of about 2. 2 is considered, 2 and greater is considered breathless, right? So she has to walk slower than other people. We had the CAT score. We asked her, do you never cough? I cough all the time. One of these scores like that.